So today's objective is really to provide information about the dying process so that we know what to expect. And so that gives us knowledge to plan for that event. I'm going to just talk about the series in general. We are at the second presentation of 5. Next, this coming Wednesday, to kind of go along with some of the topics that we'll be discussing today, we will have some TED Talks that are going to be in here in the auditorium from 2 to 3, both on being mortal and just TED Talks about the end of life. Next Friday, you will have a presentation by the chaplaincy and the navigation department about what happens to a body once we die, what are the options that we have, and then the ceremony or the memorial in terms of how we celebrate that life. The following Friday, we talk about voluntarily stopping and eating, drinking in that session. And then following that, we have an attorney coming in to talk about estate planning and talking about how things get closed out here at Crowsdale Village. We will have a death cafe on Wednesday, the 12th. And we will do, there's a session on writing a legacy letter that'll close this whole program out on the 19th of October. So, and one more piece of information here, that we do have a website. How many of you have been on the website? Yes. All right. Yes, if you go on the Vibrant website, you will see our little logo tree there, Death by Design. And if you click on that, it'll take you to a resource page. We are recording these sessions, as you just saw, and we are in the process of downloading and polishing up that first video from last Friday's session. We do hope to post that on the website for anybody to rewatch, or anybody who didn't get to see the first session to get to click on it and view that session. We are recording this one, and hopefully our goal is to have that recording on the website by the next session. So I would like to introduce the speaker for today, which is Dr. Heidi White. And quick quiz, which one of us is Dr. Heidi White? Because we often get confused. But Dr. White has actually been a pillar of this organization for many, many years. And you see her in our clinic, you see her in the pavilion. I don't know why these slides are not updated. I'm very sorry. Dr. White is a professor at the medicine school at Duke University. She's the vice chief of clinical affairs in geriatric division at Duke Hospital. She has trained numerous budding doctors over the years, has many articles that you can find if you Googled her name. She really has a focus on geriatric care, obviously, and cognitive impairment. So I am honored to look like her, but I'm also honored to work with her. She's a tremendous asset to this organization, and she is going to give you an enormous amount of information today. So.
All right. Thank you, Kim. And thank you for inviting me back to do this. This is actually, as I understand it, the second series that's been done. And with the first one was way back before the pandemic. And I guess it went so well that it has been revived. And that's wonderful to see. So thank you for this invitation to be with you today, because it's a really important topic. The world death rate is holding steady at 100%. We do all die. And it's amazing we don't talk about it more. Our culture is such that it's something that is difficult for us to do. And as I was walking in on this beautiful September afternoon, I thought, are we really going to talk about death today? But we are, because it's a very important subject, and it affects all of us in a very personal way. So I want to start with some definitions. And I wanted to find this new term that we have in medicine called palliative care. What is palliative care? And here's a definition from the Center to Advance Palliative Care. It is specialized medical care for people with serious illness. It focuses on providing patients with relief from the symptoms and stress of a serious illness, whatever the diagnosis. The goal is to improve quality of life for both the patient and the family. To work with the patient's medical team to provide an extra layer of support. Okay, but is palliative care really new? I bet there are some physicians, even a few nurses in the audience, who have practiced palliative care, who have provided care that was compassionate and focused on quality of life for older adults. And that might have happened 30 years ago, 40 years ago, 50 years ago. So palliative care in one sense is not new. Doctors and nurses and other professionals have been providing palliative-type medical care that is palliative in nature. But what is new is that we have gradually developed a specialty in medicine now. I used to say that geriatrics was the youngest specialty in medicine in the United States, but it's not true anymore because palliative care has come after even geriatric medicine as a new specialty. So now there are physicians and nurses who receive special training in palliative care. And so that is really what's new, this new area of specialization. So one thing that can be confusing is palliative care hospice care? So I think this illustration helps us to think about palliative care and hospice care. Hospice care is really a set of services provided by insurance or Medicare, and it is within the field of palliative care. But palliative care extends beyond end-of-life care. So hospice care is focused on end-of-life care when people are thought to have a prognosis of 6 months or less. And so certainly within hospice care, we practice palliative care. But outside of hospice care, we also practice palliative care. So palliative care is appropriate for individuals with serious illness. And that might be a cancer diagnosis, that might be complex heart disease. And so often it is chronic and acute episodes of care and problems that are being cared for in a palliative way. So I said that palliative care is a specialty, but it overlaps with other specialties, including geriatrics, but also primary care physicians provide some palliative care. Other specialists may provide some palliative care, but there's a particular overlap between palliative care and geriatrics. So within palliative care, within geriatrics, I practice palliative care. I'm not doing that all of the time. I'm also helping older, vibrant adults lead the very best life they can, get the preventative care that they need, get the acute care, the diagnostic care. So I'm doing some palliative care, but I'm also doing a lot of other things within the field of geriatric care. But definitely there is a common mission and a lot of overlap. At Duke, palliative care grew out of geriatrics. Many geriatricians are also palliative care specialists as well. So doctors are overachievers, and we often practice in more than one specialty. So dying is a very individualized experience. And there isn't one typical death. There is lots of room for preferences. And I think the best palliative care doctors and geriatrics doctors and other doctors and nurses are advocates for choice. We don't want anyone to feel that they are on a hamster wheel or on a pathway that is the only way. There are choices along the way, and we want to make sure that people understand what those choices are and are realizing that they don't have to follow just one course. They can ask questions. They can ask, what are my options? In fact, I once was visiting one of my patients, and she was in the hospital and she was very sick, and she'd had a surgery and she was having complications and it wasn't going well. And I went to see her and I said, remember to ask all the doctors that come and see you, what are my options? So a few days, maybe even a week or so passed, things were getting worse for her. And some of the physicians who were caring for her asked me to come back and talk with her about the fact that she might not be recovering from this, and she might have to consider a palliative approach to her care. And so as I came in and I started my spiel about the road that I thought was ahead, she stopped me and said, what are my options? And I was taken back, but it helped me to realize there were still options. And that's what I was there for, not to tell her the one road that I thought she should take, but to help her see what the options were and what the consequences might be of choosing one or another. So since not all deaths are the same, let's talk about some of the options and some of the things that may happen, ways this may play out. So some people might hope for this type of death, a sudden death. You're just going along fine, and you have a heart attack or a major stroke, and within minutes or hours, you're gone, you're dead. One of my patients recently, he said to me, you know, I'm not afraid to die. I'd just rather not be there when it happens. And we've all felt that way, right? And sometimes we're thinking this is the kind of death we'd like, right? Just to be here one day and gone the next. And especially when you're going through a series like this and you're trying to do so much pre-planning, you may think that's the best way to go. It's not a very common way to die, actually. Less than 10% of people experience sudden death. More of us will experience this kind of decline, where we have the health status on the y-axis and time on the x-axis. And as time goes along, health status is declining. Acute illnesses or crises are happening in those downward spikes. But people get better to a certain degree, go along for a while, then there's another crisis. They recover until at some point in the future, death occurs. Sometimes this trajectory is even more gradual, where you may start out at a lower level on y-axis, and you just sort of creep along down at the bottom until death occurs. And that, in layman's terms, was dying from old age. You just got weaker and weaker, and as time went on, it was hardly even perceptible what you actually died from. You just died. And so the kind of slow decline and is what a lot of us do experience. So I'm going to talk a little bit about this slow decline and this type of death. Sudden death, I'm not going to talk so much about. So I want to talk a little bit about what to expect when it's your turn, what you might expect to experience, how to prepare both then and now, how to have a perspective of hoping for the best and preparing for the worst. And to remember that it's a journey, and your thoughts, your wishes, your expectations may change along this journey. That's just part of this. As we have experiences, sometimes we change our minds about certain things. Dying is a physical, a psychological, a social, and a spiritual event. And so we really do, even physicians are thinking about this, thinking about making space for these things to happen and to happen as well as possible. I'm not going to talk about all of this because other people are better prepared than me to talk about it, but I just want to acknowledge that this is something that we're thinking about, making space for these various aspects of the journey. And there are opportunities at life's end that don't necessarily come with a sudden death. So there might be some benefit to having some expectation that death is getting closer. It makes people think about opportunities to say thank you, I love you, I forgive you, or please forgive me, and to say goodbye. So that is some of the benefit of having an opportunity before death to, in essence, get ready. You're doing some of that now, but some of it really cannot be done until closer to the event. And I get, as a physician, I get this question a lot. When will I die? When is this going to happen? And the very honest truth is that no one can predict this very accurately. And physicians are notorious for being poor predictors. It's hard for us, and we usually predict that people are going to live longer than they actually do. Although many of you have told me stories about how someone said, I'd be gone, that you'd be gone at a certain time and you're not. And maybe I've even said that to people. And we're always glad to be surprised and to be wrong. That's the best thing to be wrong about, is predicting a poor prognosis. But it is very difficult to predict, and even physicians and nurses we're influenced, I think, by our relationships with our patients as well. And death is, the timing of death is impacted by intangibles that are very difficult to measure. And sometimes I think of this as a will to live. So I see patients who are going through a lot, who have a very strong will to live. And I see people who are going through a lot, have had a very strong will to live. And I see their countenance changing. And when I see that change in that will to live, that sort of intangible, deep, spiritual, emotional will to live, it has an impact that I can see. And so I think there are a variety of intangibles that are hard for us to measure and understand, and they do influence when people die. And we have to realize that we have palliative care, physicians, geriatricians, we have signs and symptoms that we follow, but they only serve as a guide, and they're not a roadmap per se that will help us to predict accurately when someone will die. So there are two roads in this process. And we're trying as best as possible to stay on the usual road and stay off the difficult road, okay? So it's not unusual at the end of life to experience some restlessness, confusion, tremors, hallucinations, delirium, jerking, seizures. But we physicians, nurses, we're trying to avoid these symptoms as we are providing palliative care. And the more typical and the more gentle road to dying includes getting sleepy, losing energy, becoming lethargic, obtunded, what we call semi-comatose, comatose, and essentially dying in one's sleep. Okay, that is the gentle road that we are trying to guide with the medicines and the various things that we do. So I'm going to talk about a lot of different symptoms now, and what they are, that they may occur, and some of the things that we do to help with them. Some we can do things about, some we can't do so much about. So social withdrawal, some, as people are approaching death, this would be especially in the weeks, days, or hours before death, will often experience a turning inward and a separation. They're sometimes glad to see family and friends, but there's also times where they're not wanting to be talkative. They're not wanting to be with people. And so understanding that that doesn't mean they don't love you, they don't care about you, but their capacity for truly engaging is diminishing in the dying process. Sleep, more time sleeping. So many people are experiencing this, and they're going to sleep at night, they're going to sleep during the day and have low energy. And they may have difficulty talking and breathing at the same time. But at the same time, they may have short bursts of activity where all of a sudden they sort of have a burst of energy, and it can be it can be very jolting for a spouse or an adult child to see this burst of energy and it just feels like maybe this isn't going to happen. But that burst of energy often is relatively short-lived and the sleepiness resumes. Also, people, as they approach are approaching death in the days and hours before death, sometimes weeks, they have an awareness that they are approaching death. They may not talk about this in very overt ways, but they may start talking about people who have already passed on. They may act like they're getting ready to go someplace. So they may talk about things that make you think that, yes, they have a concept of what's happening. And they just, even if doctors don't tell them, and we're notorious for not telling people that they're dying, people know often when they're dying. My husband over and over tells the story of when he went to the hospital to see his father for the last time. And he said, "Dad, do you know what's happening?" And his father looked at him and he said, "Yes, I'm dying." That was he wasn't thinking about the atrial fibrillation and the heart failure and this and that and the stroke. And it was very clear to him, I'm dying. And so it's not uncommon for people to have a sense of knowing, even when they're sort of going in and out, a little bit confused. People aren't talking to them directly. And as usual, doctors are talking in a doctor speak and not patient speak. And so, what we actually want to say isn't very clear. And it's probably best not to correct them. But adult children are notorious for correcting our dying parents. So I'm grateful that my husband didn't say, "No, Dad, you can get better." He didn't say that. He just listened. He was just there. He was present. And we'll talk about that a little. Energy surges. This happens. When it does happen, it's wonderful. Patients who've been very sleepy for several days may wake up and ask for food. And they haven't asked for food for several days. And so it can be wonderful to see this. And it should be viewed as a gift. However long that energy surge lasts, it's a gift. But often the story goes, they had a great day and then they passed away. And so that is sometimes what happens. Food and fluid. Generally speaking, people will have less need for food and drink as death approaches. And if they are going to have something, they may want something soft, some ice cream or yogurt or pudding, and liquids. They may want to drink liquids because their mouth may feel dry. They may be doing a lot of mouth breathing, not breathing through their nose, but breathing through their mouth. And yet they may be having more and more difficulty swallowing. So this can be problematic. And women, especially, we get very distressed when people are not eating because that's what we do to show love. We feed people. From the time we had babies, children, loved ones who were ill, we've spent a lifetime feeding people, and it can be very distressing that people are not eating as they're dying. But it's part of the process. And generally, people do not feel hungry. And that's why they're not eating. They don't have an appetite. They don't want to eat. And if we encourage them too much to eat, we can make them sick and feel worse. We can make them nauseated. We can make them vomit, and we don't want that to happen, okay? This is part of the natural process of going to sleep and becoming comatose. And so what we do often is provide swabs to swab the mouth to keep it moist, rather than fluids to swallow. If the person can't swallow, we can still paint the mouth with water, with a sponge. We can use glycerin suppositories that keep the mucosa moist without having to swallow water. And sometimes the senses are declining, okay? The sense of vision, the sense of hearing can be leaving. So as you know, as we think about death, and my husband is a neuroscientist, so I think about the death and sort of the outer parts of the brain, the cortex and what it controls, our ability to talk, our ability to hold a conversation, our ability to process visual stimuli. Some of that is dying, and the very deep central parts of the brain remain, where that's the drive to breathe. The drive that for our heart to beat is in the very inner parts of the brain that is the last to die, okay? So people are breathing, their heart is beating until it stops. And but the other things that the brain is doing are becoming more disconnected. And so vision, so people may be staring past you, and not seeming to be engaged or seeing the person in front of them. And so it's what they're seeing, what's being processed may be going. It's always best to assume that they are still hearing. And we encourage family members to speak to the person, to touch the person, that their sense of touch, their sense of hearing is still helping them to know they're not on this journey alone. But there may be unusual behaviors and not engaging with vision. There may be the loss of ability to close the eyes. Small layer of fat behind the eyes can shrink. The eyelids cannot cover the entire eye. There may be redness and dryness that can occur. And we try to deal with that in various ways with drops and the like as people are in the dying process. Changes in breathing. So irregular breathing is very common. Something that we call Cheyne-Stokes breathing, where people breathe very heavily and fast, and then they're breathing slowly. It gets very, very shallow, may stop for a very brief period of time, and then the whole process starts again with deep breathing, heavy breathing, and then gradually more shallow breathing, almost to stop, and then the cycle repeats itself. This is normal. This is a normal pattern as people are dying. Closer to the end, there may be moist, noisy breathing. Some doctors have referred to this as a death rattle. The idea that there's mucus in the airways, that the person is very weak and not able to cough it up. And so it rattles and it makes noise. It's usually not for that uncomfortable for the person. It's not as uncomfortable for the person who's dying as it is for the person sitting and watching this happen and listening to the noise. But this is something that you can speak to the nursing staff about. Just good nursing, just turning the person in bed can often move those secretions around and so that the person is not, things are draining a little bit different way and they're not rattling and making so much noise. But this is often seen towards the end, near death. Pain. So pain is something that we certainly want to be observing the patient for, not just asking, are you in pain, but actually observing. Is someone grimacing? Are they moaning or groaning? Are they telling us in ways other than language that they're in pain? And we want to do something about pain when it is part of the dying process. And we have a variety of medicines that can help with this. Many medicines now are available so that you don't have to swallow them. Morphine can come as a very concentrated liquid that we can put under the tongue, and it can just be absorbed in the mouth by someone who's not swallowing anymore. Other opioid medications like morphine can be given as a patch on the skin. So there are various ways. We don't necessarily have to give an injection or an IV to get these kind of medications routinely into the system when someone is dying. Loss of bowel and bladder function. This is also part of the dying process. Urine is often becoming dark and decreasing. So if you're not drinking fluids, you're not going to make very much urine. So urine becomes dark, and the body will close to the end may stop making urine altogether. Also, people can lose control of bowel and bladder. And again, this can occur near the end of life. And it's just part, again, it's part of, our brain controls everything that we do. So this isn't something that can be helped necessarily. It's just part of our brain lacking full control over these aspects of daily living. Skin changes. The color and temperature of skin may change. Fever can be very common at the end of life. Hands and feet may be cold and kind of patchy blue, mottled, we call it. And blankets are not necessarily going to help with this kind of cold feet and cold hands that is coming. It's a sign that death is getting closer. Confusion, moaning, restlessness, pulling at bed linens. Many, many people experience some degree of confusion. We call it delirium as in the dying process. This can be very upsetting. And it's really important to talk with the medical team about this happening. And it's important simply to speak calmly, reassure the person. Presence can be very, very important for this type of problem. And we have medications that we can use to help when this is happening. Seizures, or what we call myoclonus, jerking movements of arms, legs, and the head can also be common near the end of life, and sometimes full-blown seizures. But again, there are medications that we can use for this. Sometimes this is a problem that I've seen where we have hospice care in the pavilion, and we can do a lot of We can do a lot of palliative care in the pavilion. We do it with and without hospice. But when seizures are a problem near the end of life, sometimes that's when an inpatient hospice facility like the Hawk facility over on Roxborough Road can be very helpful when we're having to manage these types of symptoms near the end of life. So occasionally, you know, those kinds of facilities are very, very important. Shortness of breath, air hunger, very common, and it's scary for everyone. The person may be using extra muscles to breathe, and that's uncomfortable for the person too. But their medications like morphine can help to slow breathing and make people more comfortable. Although there's always a concern, and you may have heard that medications like morphine can stop people from breathing, but we're giving these medicines not to stop people from breathing, but to make them more comfortable. Okay, so there's a difference, and it is a medicine that truly can help people feel more comfortable. Bleeding. Bleeding is fairly uncommon as a way of dying, but it does happen. And it can look very scary. But the thing to remember is that it's not generally painful to be bleeding. And it's not as uncomfortable for the patient as it is for the people watching, okay? So if you're bleeding and your blood pressure is dropping, you're starting to feel very sleepy and dizzy, and it's a going to sleep process as the blood pressure is dropping. And so, but it's very distressing. It's very distressing for nurses and for the people watching this happen on the rare occasions when it does. Nausea and vomiting. Usually less of a problem as death approaches. Why? Well, because people stop eating. So they're not eating and drinking, and they're not getting nauseated. Sometimes people are getting very nauseated as they're approaching death because they're trying to make everybody happy, and they're trying to eat just like that loved one is encouraging them to do. But when we stop that, oftentimes the nausea and the vomiting go away. And over a lot of nursing techniques can help with this kind of thing. And we certainly have medications that will help as well. And this is something that, you know, can happen at the very last moment of death too. You know, on television, death looks so calm and peaceful and beautiful. But in real life, death is a process. And there are good moments and there are bad moments for everyone. And what we're trying to do as a medical team is to help the good moments be more and the bad moments be less. Other physical changes, body temperature fluctuating, fever, increased perspiration, clamminess of skin, entering a coma before death. These are the things that we expect. Symptoms of imminent death. Again, the legs and arms cold and blotchy, decreased or absent urine output, vital sign and breathing changes. Usually, if we're expecting someone to die, we stop taking vital signs. We take them off the monitor at the hospital. Why? Because it's just, you know, sometimes it's uncomfortable to have your blood pressure taken in clinic, right? Is that what you want to have when you're dying, when we're at a point where we're not going to do anything about that blood pressure or that pulse? Sometimes we're kind of data-driven people and we want to know, you know, how fast is the heart? What's the blood pressure now? But if we allow ourselves to step back from that data and just be in the moment with the person and not continue to submit them to these medical practices, we can make that process of dying more peaceful and less medical in the end. Congestion, noisy breathing, and just relaxation. So as people, you're with somebody who's dying, you know, in the early stages, they're holding your hand, they're gripping it firmly. As they're getting closer and closer to death, they're not responding to your touch. They're not making any muscular motions. Their face is getting very relaxed. The muscles of the face, the muscles of the hands, they're not showing you any kind of reaction anymore. And I know many of you have had a variety of experiences sitting at a bedside. None of us have accomplished death in this room ourselves, but we've been there with somebody else. And though these experiences have a profound impact on our thinking and our own expectations. And I just want to acknowledge that and the questions that may come as I finish today. How do we know when death has occurred? I've heard some families say we didn't even know she was gone, and they feel bad about that. You know, it wasn't until the nurse came in and told us she's gone, but it can be hard to tell. But no breath or heartbeat, sometimes loss of control of bowel and bladder, no response to voice or gentle shaking, eyelids open slightly, eyes fixed in a certain spot, jaw relaxed, mouth often open. These are some of the things that we see commonly when people have passed. And it can be difficult to pick the exact moment because the heart is kind of in an irregular pattern, and there may be some coming and going of blood pressure and pulse towards the end. And just to say that our presence, whether we're a physician or a nurse or a family member or a friend, we're not guides. We haven't done it, so we really can't guide someone through this process, right? But we are there to keep watch and to be present, and being present is doing something. And it's okay if you don't have words. It's okay if you don't have words. Your presence is important. And one of the residents over in the pavilion, he keeps telling me over and over about his experience with his wife and how much he appreciated the physician who just sat with him for a period of time and made it possible for him to sit with his wife near the end and make that a peaceful situation for them. That was very meaningful. I think he keeps telling me this because he's hoping for a peaceful outgoing for himself at some point. And I just wanted to introduce you to a really talented palliative care doctor. His name is Nathan Gray. He was here at Duke practicing palliative care until just recently. He moved to Johns Hopkins, and I can't begrudge him that. He went from one wonderful medical center to another. But in addition to being a palliative care physician, he's also an artist, and he does this type of cartoon drawing. And so I thought you might enjoy his website and some of the work that he's done. Much of it's been published in medical journals, also the lay press as well. And one of the things that he wrote was, and so it's pictures and words and it's stories. And dying words aren't what I imagined. So he's a relatively young palliative care physician reflecting on what he's learning as a palliative care physician. And dying words aren't what I imagined. So he talks about all the different things that people say as they're dying. It's quite a variety of things, and also makes the point that near death, people are not speaking very much at all. And that surprises people because in the movies, people are always talking right before they die. And so when the doctor says, tell the family to come now, it's for a reason. Tell them to come now because the person is talking and they're not going to be talking the closer they get to death, okay? It's not going to be as meaningful for those people to show up at the very end when no talking can occur. It's much more meaningful to show up when the person can still talk. I also thought that what he had to say about CPR, cardiopulmonary resuscitation, was quite enlightening. I think you might want to look at this and, to realize how cardiopulmonary resuscitation, it may be what you want. And I want you to have options. It is an option, but it is not a peaceful death. No one will be holding your hand if you die during cardiopulmonary resuscitation. And that may not be important to you, but it is heart-wrenching, actually, for many young physicians and nurses to try to resuscitate people that they feel are not at all likely to be resuscitated. And he kind of talks in this short story about how cardiopulmonary resuscitation can be very effective in certain circumstances, but it certainly wasn't envisioned to be applied to the masses the way we do now. So we apply it very broadly and perhaps don't talk with people ahead of time enough about whether or not it's an appropriate part of the living and dying process. And then the last one I'll emphasize is just the weight of caring at home. So as a palliative care physician, he's going into homes and going into various places where people are dying. And he's not only talking with the patient who's dying, but he's talking with the people who are caring for them, usually family members. And he is providing them, he talks about standing on the porch and wiping the tears, giving time for tears on the porch, because the caregivers are the ones who need care as much as the patient needs care. And so I bring this up because we in this community are so blessed. Yes, the weight of caring is there. It's there for spouses, but in this community, it's there with a lot of support. It's there with people like Kim and the program that she runs of home care. It's there with the pavilion. It's there with the medical staff, the nursing staff, the chaplain staff. And not only that, but the community that you provide for each other, the friends, the longtime friendships many of you have who've lived here locally. It's just the weight of caring in this community is perhaps less than this palliative care physician experiences in his more general practice of palliative care. And I tell you, palliative care doctors love to come here on site. We have great relationships with Transitions and with Duke, and the palliative care doctors who come here on site are, they're glad because they see the support that people have and what a difference it can make. All right, I think we're
awesome. Yeah, I'm going to transition
this
just
is
a little bit.
Kim's.
Yep, and it's going to bounce off from everything that you have just said
so wonderfully. So, that was excellent information, by the way, and I think it gave us a lot of tools. Yes. She's phenomenal. I'm so blessed to be able to work with Dr. White. it's a lot of information, but I think I wanted to just touch a little bit on the logistics, because people will say, family members, residents, spouses, okay, I may be at that point where I'm dying. What are my options here at Crowsdale? So we do have the ability to have somebody die at home. That can be in a cottage, it can be in an apartment, it can be in assisted living. We have the ability to have hospice come in. She just mentioned a couple of different hospice organizations. They are very, very supportive in that situation. And we highly recommend that if you have chosen that I really want to die at home, that hospice is put in that situation to help support you in that realm. And we also have a home care organization here. So one of the key things that I want to point out with the home care organization that I run is that one of the misconceptions of home care is that I will get an aide to come into my home and they will take care of the things that I need. We have a huge limitation with our aides, our certified nursing assistants in a home from my home care agency. They do not have the scope to administer medications. So if somebody is at the end of life and they are needing some morphine or some Ativan or some Haldol, and they need that medication administered, the aides from a home care agency cannot do that. And that tends to be a little bit of a trip up for folks who want to die at home. And there needs to be some planning around that. Aides from home care agencies can come in and they can turn you in bed. They can wash you up. They can swab your mouth out if it's dry, put lipstick or chapstick on. They can do all sorts of wonderful things to keep you comfortable, but they are not allowed to administer medications. Many, many times, there is a supportive family member there that says, I'm going to sit next to mom's bedside, dad's bedside. I'm going to be here when my dad or my mom can't give those medicines, and I'll be the one to notice that mom and dad is uncomfortable and that I'll give some morphine or I'll give some Ativan. And many times that's important to that child and it works out very well. But if there is somebody who says, I don't know if I'm really comfortable with that, you know, then it gets to be creative. We have to figure out a creative solution because the aid that comes from a home care agency is not allowed to give medicines. So it's one of the specifics, one of the things that trips us up when somebody says they want to die at home is we want to support that as best as possible. We've got to find a way that when that person cannot administer their own medicines, they may not be alert or oriented, but they may need some morphine. They may need some Ativan. They may experience confusion or pain that needs to be addressed, that we figure out some other person, some other way at home for somebody to do that piece of the puzzle. Now here at Crowsdale, we have the pavilion. People have 6 free days a year. Somebody can easily be admitted, usually within 24 hours, to the pavilion, where you've got nursing staff there 24/7 to administer those medicines, to identify when somebody is uncomfortable, to take care of a lot of those things that Dr. White just talked about. And that option may feel more comfortable to folks. As we said, this is a journey of choices, and sometimes residents, spouses, family members, sons, daughters, they need to kind of figure out what is comfortable to them. You can have a wonderful, peaceful death in the pavilion, surrounded by some very talented medical staff that can make sure that you're comfortable. You can have a peaceful death at home. Many people die in cottages, in apartments, peacefully. And it just takes working with your navigator and working with the family that's here, the support system that's here, to be able to understand what that looks like. And I also don't want to leave out one piece, which is the Hawk House. So when somebody gets to the very end of life, the Duke Hospice has a wonderful inpatient facility not far from here. Hospice houses are beautiful, peaceful places that provide a wonderful experience for that end journey. And that's definitely a resource. People can say, I think that's what I want to do. It does require Duke Hospice to authorize that admission. It requires for them to have beds available. So there are other little obstacles when it comes to Duke Hospice and the Hawk House. One thing that I don't think we've mentioned too is there was some conversation on Wednesday, and I want to just clarify, when you talk about hospice services, I think there may be a little bit of a misconception sometimes that, well, I've got hospice and they'll take care of everything. Hospice services do a great job of providing very talented nursing staff to come in. They come in maybe once a week for a while. If you're at the end of life, they may actually come in once a day to make sure you're comfortable, but they're not going to stay there around the clock. The hospice support is not around the clock care. It is a phone call away. You always can call somebody, and you can get a nurse that comes out maybe within an hour, hopefully, or an hour and a half, but they do not provide round the clock certified nursing assistants, and they don't provide nurses around the clock. It's a support service. They're going to consult with you. They're going to advise you. But there are pockets in that you are going to want to, your family member, your spouse, whatever, are going to need to understand and to fill when that time comes. So, and we have obviously some wonderful chaplaincy service here too. And at the drop of a hat, day or night, you can call our chaplaincy service here. They will come out. They will find somebody to come out for whatever spiritual need you might have at any time, day or night, to be able to just kind of make your family feel better during that time. So I'm just going to wrap up real quick, and then we're going to get to some questions because I'm sure you've got a lot. Just in summary, the dying process, death can be a profound experience for patients, for families, and for caregivers. And caring for dying patients and families is intensive and holistic at Crowsdale, with a variety of resources to call upon. And understand too that care does not stop when somebody dies. There's a huge support system here for that grief process, that bereavement process as well. I'm gonna take an exhale there. I'm just gonna remind everybody that our next session on Wednesday is gonna be a TED Talk here from 2 to 3:30. And next Friday, we're going to talk about what do loved ones do after death, talking about the memorial, talking about what happens to a body after death. I know you got your slides and you got your evaluation form. If you want to drop that evaluation form off at the table in the back, you're more than welcome to do that. We also have a box down on the life enrichment counter, so you can also do that. And with that said, are we ready for microphones? Caroline? Oh my gosh, she abandoned me. Okay, well, I'm going to have Dr. White come up here. I've got a microphone, so if somebody has a question, I'm sure it's for Dr. White and not me. Does anybody have a question? And I'll hurry you.
There's a question right down front here. Do you want to? You can shout and I'll repeat it. Yeah. Obtunded. Obtunded means that you're not arousable. You know, you're kind of sleeping to the point of not being able to be awakened. So usually when you're sleeping, you can be awakened. When you're obtunded, you can't be fully awakened. You might rouse a little bit, but you're not fully arousable. You know, some of us wake up slowly. Yes, it might take us 5 minutes or 50 minutes to wake up, but obtunded is beyond that. Very, very difficult to wake up. Yeah. Okay. The question is, what if you enter hospice and you live longer than 6 months? It's a wonderful thing if you enter hospice and you live longer than 6 months, okay, first of all. And the reality is that when they've studied this, people who, you know, us doctors are far too late in getting people on hospice. So I have to tell people, I'm not expecting you to die right now, but I want you to get on hospice because I want you to meet the people and I want them to know you and you to know them so that when the time comes, it's a good process. So the people who go on hospice actually do live longer than the people who don't go on hospice, in part because we stop doing things to them. When we're doing things to people, we think we're helping them live, but sometimes we're making things worse and we're hastening their death. And if we stop doing it, they get better. Maybe not completely better, but they get better, okay? And that's actually what happens on hospice. So you're allowed to live longer than 6 months. In fact, I think my longest patient on hospice was about 4 years. But if you continue to be in a near-death kind of situation, you can stay on for 4 years. Some diseases, no, cancer is predictable. We have a lot of research around cancer, and cancer for the most part is a very predictable course. And we know when people have outstretched all of the medical interventions that we have, and we know how quickly people die with certain cancers. Heart conditions and heart failure is much less predictable. And that is a situation where people tend to sometimes live longer periods of time and sometimes graduate from hospice. This is something else that can happen. My husband said, this is crazy. You graduate when you die, right? I'm like, no, you graduate when you actually come off of hospice and you don't need it anymore. So occasionally people get better enough that they come off of hospice and they don't need it. They may go on back on later because this is hard to predict, you guys. Even very talented doctors at Duke University sometimes put patients on hospice and then they graduate. And it usually is a situation of chronic heart failure, things like that, that are a bit more difficult to predict. Yes, you have the option on hospice to either keep your primary care doctor or switch to the hospice doctor. So in different situations, it's different. So like in the pavilion, because the hospice doctor isn't there and I am, I don't turn those over to the hospice doctor. But sometimes in a cottage, when the main person you're interacting with is the hospice nurse and the main person she's used to interacting with is the hospice doctor, it may make some sense to switch over to the hospice doctor for those prescriptions and everything that's required. So, right, there should never, you shouldn't have to move to the pavilion because you don't have access to prescriptions. That with hospice, that can be worked out either with your primary care or with the medical director for the hospice provider, the hospice company. There should never be a lack of access to medications that are needed. And the medical director of hospice, even if you're with your primary care and for some reason the nurse is having trouble, the hospice medical director will usually step in if there's any problems at all. So that shouldn't be a problem. How far away is professional assisted care for our state? Is it being addressed? Kim is going to help me with this question.
So yes, actually there is a bill that is sitting in the State House that's been sitting there for I think 2 years and just hasn't been voted on. But I follow. I get emails from an organization called, I think, Death with Dignity, something along those lines, and they kind of keep me updated on that. And it just hasn't gotten to the floor in order to be voted on. But I think it's been there for about 2 years. Okay, so kind of 2 questions. So questions regarding when I am somebody, a resident at home, how do I get on hospice care? How do I get on palliative care? And how do I arrange to die at home? So good questions, actually. The doctor, Dr. White, is going to be writing a referral for palliative care and for hospice care. So that's a conversation that you have with the clinic doctor and that you're all on board. That referral goes to Duke Hospice. It goes to Transitions Hospice, whatever hospice you decide you want to go with, because there's several out there. That hospice organization comes into your home, explains the services, and if you're good with that, they sign you up for the palliative care or the hospice at that point. If you choose to want to die in your apartment or your cottage, that is definitely something where you get your navigator involved so that we understand all the things that need to happen and the supports that need to be in place at that time. And maybe you have a very supportive family or friends, and we have to understand that whole thing and all those things that Dr. White so eloquently talked about, will be brought in as this can be the experience, and are we ready for this experience to unfold in an apartment or a cottage, or the choice being, here's the pavilion and this is how this would be supported to you. And
I'll just say that, remember, hospice, so you have to have a hospice referral. Your primary care physician has to agree that you have a diagnosis that qualifies you for a prognosis of, on average, 6 months, okay? And then there are things that hospice, they have certain criteria as well, like there generally has to be a caregiver. They have to have somebody to work with, not just the patient. So there are various criteria that have to be met for hospice services to be appropriate, right? Palliative care is a referral, is a consultation, like a consultation with a cardiologist or a nephrologist. And generally those palliative care referrals or consultations, that's covered under your usual insurance. And there are, so if you go to Duke and you get a cancer diagnosis, they may refer you to the palliative care doctor, not because they think you're dying, but because they want the palliative care doctor to help with symptoms, symptom management, symptoms from the cancer, symptoms from the treatment, and getting conversations about getting ready for. So there are palliative care doctors that you would see in a clinic. There are some organizations like Transitions and Duke Home Health and Hospice that can, in certain settings, provide palliative care consultations. Transitions has a more robust program of palliative care doctors who will come here on site to see people. Palliative care is something that is still growing. We have more access than most communities to palliative care. And because we do have palliative care doctors who will come on site, we have palliative care doctors in clinics, not just in the hospital. In some communities, there's so few palliative doctors, they're only in hospitals. You can't see them in other places. So it's just wanted to clarify that a little bit.
So the question is there any organization that facilitates assisted death? No, but I do understand. I think that if you go to another state, you have to be there for a certain amount of time. I think you have to have residency for a certain amount of time. And there is a process, even in states that have legal assisted suicides, there's a very rigorous process in terms of making sure that doctors that you talk with are all understanding that this is, that you understand what this means. There's a lot of signing off that needs to go on. So I don't know of any. I think those organizations may be more located in other states than in ours. Yeah, let me just rephrase that so that others know. It has to do with morphine and being able to, I think, divvy out the morphine according to your values. Do you want this to be comfortable? You want to be comfortable? You want to be able to interact with your family? And how does that apply in the pavilion versus a hot house versus at home? Dr. White's going to take that.
Okay. Right. Well, you're bringing up some very important points. And the right amount of morphine is something that needs to be discussed with the patient and the fan, or any other medicine, other medicines as well. Sometimes we're giving medicines for lorazepam, which is Ativan, haloperidol. All of these medications can be very sedating. So it's really important to have conversations about what matters to the person right now, just like that nurse or doctor did with your husband. What matters? Are there people you're waiting to see? Are there conversations you still haven't had? And sometimes what can make it really difficult is that different patients and spouses and children don't always have the same thing that matters to them, the same thing that matters to them. So it can get very complex at times, but these are the conversations that need to be had. What's the goal? Is the goal not to be in pain? Is the goal to be as awake as possible? What is the goal? And so that's what has to be kept in mind. And generally speaking, in the pavilion, we try to schedule pain medications as much as possible. Once we realize how much people are, sometimes it may start out as needed, but as we're seeing that people need it and the nurses are giving it, we start scheduling it, because it's better to stay ahead of the pain than to have to chase the pain with medicine. We don't want to wait till the pain is severe. So we have to get everybody on board, and we have the nurses understanding what the goal is, everyone. And so we try to schedule medicines because we want to stay ahead of the pain. And we can usually do it fairly, nurses can do fairly frequent. So sometimes the medicine is scheduled every 4 hours. At times they may have to give medicines hourly. We have to look at the individual situation. That may be another situation where if we're having to give very, very frequent medications, where we might be talking with hospice about the Hawk Pavilion, someplace where there's even more manpower to do that kind of intensive nursing that's required. So oftentimes, Hawk Pavilion is not a place you can say, that's where I'm going. That's where I want to be at the end. It's a conversation between your family at home, if you're at home, and what the needs are, or the doctor, myself and other doctors in the pavilion and the nurses, what we can do there, whether we can meet the needs. It's about meeting the needs, okay? So if your needs can be met at home with your family, that's ideal. But these are conversations that have to happen, and there has to be agreement that perhaps, you know, there are situations where we outstrip the nursing capabilities in the pavilion, and usually not. Usually it's not a problem at all, but occasionally we have to admit that people need to move on. And usually hospice is in there saying, okay, this is the time. They know, they do this so much. They know when it's time, when the needs of the situation have outstripped the family members at home, the staff in the nursing home. They know when this is needs to be considered. Mm-hmm. Okay, the question is, what does a physician need to know with regards to a situation where somebody is diagnosed with Alzheimer's disease and may ultimately be in a situation of dying from that illness, and how to kind of fulfill your wishes. So the first thing we need to know is what your wishes are. So, you know, it's okay to write them down, talk to your family about them, and talk to your doctor or your advanced practice provider. If you have a nurse practitioner or PA, talk to them, say, you know, Alzheimer's is in my family. And if I get it, I want you to, you know, I want this to go as quickly and as smoothly as possible if I'm going to die from this. Now, Alzheimer's happens to people who have heart disease and cancer and other things, and you may not die from Alzheimer's disease. But you can die from Alzheimer's disease. If you're healthy enough, you can die from Alzheimer's disease because it affects the brain to a degree that you can die from it. And so it's helpful for us to know, what do you think about this situation? What are your wishes? And so there are, you all learned about most forms and how if you have a terminal illness like cancer or Alzheimer's disease, you can say, you know, I don't really want to take antibiotics. If I get pneumonia is the old man or woman's friend. That's what doctors used to call pneumonia, the old man's friend, because pneumonia was a way to get sick and within a matter of days die. And, you know, before antibiotics, it was the old man's friend. It was a quick death. Within a week, people were gone. So, you know, you can you can indicate that you don't want to take antibiotics and you don't want to go to the hospital and you don't want anything that would potentially extend your life. What kind of diagnoses qualify you for hospice? It has to be a terminal diagnosis, a diagnosis that is going to cause you to die. So, and to die within a 6-month period of time. So that could be heart disease, that could be cancer, that could be a severe stroke or multiple strokes that are causing an obvious, clear decline and inability to maintain nutrition, hydration, things like that. So just about any terminal diagnosis. Alzheimer's disease does not qualify for hospice until there's other evidence that the life expectancy is less than 6 months. And that means significant weight loss, pressure injury to the skin, repeated infections, that kind of thing. How do we know it's time to do a DNR? You know, that's a very individual decision. It's really a very individual decision. A DNR is a do not resuscitate order, okay? So when you do a living will, you say, if I'm terminally and incurably ill, I don't want life prolonging measures. That can at some point be interpreted as a do not resuscitate order would be appropriate, right? But it's not a do not resuscitate order, right? So just because you have a living will doesn't mean you have a do not resuscitate order. They're two separate things, okay? If you have a living will and you're in a car accident, you go to the hospital and they do everything they can for you, including resuscitate you if you don't have one of those yellow do not resuscitate order sheets, okay? And even if you have a living will, they're going to do it all because they haven't determined if you're terminally and incurably ill from your car accident. So they're going to assume that you want everything to be done, even if you have a living will, okay? But a do not resuscitate order is something that it's very individual. Like some people say, I don't want to, you know, I know right now that if I died, I wouldn't want someone to revive me. So some doctors in the hospital say they wish they could have DNR tattooed on their forehead because they don't want to be revived. Whether they've actually signed or had their doctor sign a yellow DNR for them, I don't know. But some people say that. But so it can be that you can be perfectly healthy and you can have a new diagnosis of Alzheimer's disease and you can say, it is time for me to have a do not resuscitate order. I have a new diagnosis of Alzheimer's disease and I'm ready. You know, if something happens, I want to take advantage of it and I don't want to be revived. But other people may say, I'm healthy. I may be 85, but I'm healthy. I don't have heart disease and I don't have lung disease. And if my heart stops and I'm in the dining room, there are, you know, we have defibrillators that can be put on you and attempt to revive you. So it's a very personal decision. When is a DNR? There are times when people will ask you, when you go to the hospital, you should be asked if you want a do not resuscitate order. When you go to the nursing home, if you're going for short-term or long-term, you should be asked, do you want a do not resuscitate order? If we don't ask, we don't give people the opportunity to think about it, decide, then people end up being getting care that they don't necessarily want. In a community like this, you all are very knowledgeable. You know, you've studied, you've researched this, and you're much more knowledgeable than the general public. The general public is still somewhat naive about what a do not resuscitate order is and when it might be appropriate for them. So I can't say there is one time. And some people never have a do not resuscitate order. They always want. That's just what they want. They want us to try. So that's okay. We will. It's probably not a satisfactory answer. The question is about a do not resuscitate bracelet. Well, just like the doctor who wanted to have DNR tattooed on their forehead, that's not official. So you run the risk of it not being followed because it's not official in our state. Yeah, right. It has, do not resuscitate is an order that has to be signed by a doctor. All right.
just say, thank you all so much. If you have an evaluation form, you can put it in the back. Thank you. And we will see you on Wednesday and then next Friday and then the Wednesday again and next Friday. So thank you so much.